Bismillahirrahmanirrahim. Assalamu alaikum. I thank all the participants, the organizers, and the worthy professors sitting here, especially at the end of the session. All of you seem to be tired, but let me say a few words about this most well sought, landmark study, and also one of a controversial study. Ischemia trial. Let me first let you know what is ischemia trial. Ischemia trial is an international study of comparative health effectiveness with medical and invasive approaches. Basically, this trial follows the previous Courage trial, the previous FAME2 trial. Those trials also came to the conclusion that invasive study or revascularization in stable patients, coronary artery disease, stable coronary artery disease patients was not superior to optimum medical treatment. So in this trial, again, this early invasive strategy was compared in about more than 5,000 patients with optimum medical therapy followed by invasive therapy leading to revascularization in those cases who did not respond to optimal medical therapy or who developed more angina, became unstable, or went into ACS. Now, the first point is that this study, which says, because they actually postulated when they started the study, that the invasive arm of the study will be superior to an optimal medical management in patients with stable coronary artery disease who have moderate to severe ischemia documented on an imaging study. So, this is how this study proceeded, more than 5,000 patients. The primary outcome was cardiovascular death, all-cause mortality, MI, unstable angina, hospitalization, heart failure, or resuscitated cardiac arrest at 4 years. So this is the brief comparison of 13.3% of the invasive group versus 15% of the conservative group. So there was not a big difference. There was not a significant difference statistically. So both of the arms, they landed up with nearly equal outcomes. The ischemia trial slightly more explained in this picture. CT coronary angiography was performed, blinded coronary CT angiography in 73% of the patients. But these patients were excluded. This was the major exclusion criteria of unacceptable angina despite medical therapy, ACS within 2 months, patients who had PCI or CABG within 1 year, or patients who were in NYHA class 3-4 of heart failure, patients with left ventricle ejection fraction less than 35%, or patient with chronic kidney disease. So another arm of this study was continued in those patients who had GFR of less than 30 ml. Core lab anatomy was seen, was the patient eligible, and then they were randomized into the already, as I mentioned, invasive strategy arm plus optimum medical therapy. In the invasive strategy arm was people who were also on optimum medical therapy. And they were put for coronary angiography, and then it was decided whom to go for PCI and whom for CABG. And in this also, nearly 70% went for PCI and nearly 25% went for CABG. And on the other hand, the conservative strategy was optimal medical therapy alone. It's a large-scale study of over 5,000 patients who have stable angina and had abnormal stress tests randomized to OMT or OMT plus revascularization. Primary and secondary endpoints already mentioned: composite death, MI, revascularization, etc. Secondary endpoints: quality of life, angina. These were the patient's details. 77% of the patients were male, 66% were white, 40% of the patients were diabetics, 19% of the patients had prior MI. Severity of angina was measured by Seattle Angina Questionnaire. Most of the patients had angina on monthly basis. Few had only weekly basis, because if somebody is getting angina weekly or every day, they were excluded. So this was the graph showing cardiac catheterization and revascularization. 96% of the patients had cardiac catheterization. Out of them, 80% had revascularization, in which 74% underwent PCI and 26% underwent CABG. So the primary outcome of this study, if you see the graph lines, they are nearly going together, and this study was carried out for nearly 3 to 4 years. So what they postulated was negative. There was no difference in the hard endpoints. There was 1.9% increased risk in invasive category in the first year of primary endpoint, but the curve crossed after 2 years. So this is the questionnaire. Now we come to the most important part of this study. The reason this study is being presented today is that we want to know, or we want to question. This study has been questioned. There is a lot of controversy, because earlier studies showed before that, like Bari, there was a cooperative study, veterans cooperative study, and CAS study, which showed that people who had high risk, people who are in high risk, and they had got even stable coronary artery disease, the guidelines still considered them for revascularization. So these new studies like Courage, like Bari 2D, and like this Ischemia trial, they came up that no, what has been seen practically, comparing these two arms, the outcomes are nearly the same, especially in patients with stable chronic angina, stable chronic ischemic heart disease, with moderate to severe ischemia documented on imaging study. So what are the limitations? The limitations are a fairly sizable patients were thrown out of the study because they had positive stress test but no significant disease on CT angio. The unblinded trial, no sham procedure was done. Study results were not applicable to ACS within 2 months. Highly symptomatic patients were already excluded. Left main was excluded. Left ventricle ejection fraction less than 35% was excluded. These findings may not be generalizable. Centers with higher procedure complication rate, but these are the facts, that this is what was done with this study. Completeness of revascularization was not assessed. Only 80% of the patients in invasive group received revascularization. Less women were enrolled Only 23% were the women in this study. Hospitalization with unstable angina, heart failure is higher in conservative groups, slightly, but it was not statistically significant. Long-term follow-up may show us that the patient undergoing CABG and PCI may do differently. Now, this study was also only for 3 to 4 years. If we go for a longer period, maybe the results are different. There may be more benefit of CABG than PCI and vice versa. So, lot of controversies arise. So, on this platform, I open this to discussion among all our worthy colleagues sitting here. If they want to give their comments. From my side, 20% of the patients in invasive group were not vascularized. Reason told was not suitability for revascularization. Optimum medical therapy group, 23% patients received PCI at 4 years, which is a significant crossover. 40 in the optimum medical therapy group. 49% of the patient had no angina 1 month prior to the enrollment. This may be a reason for no different study results. So these are what we have gathered through our research on these studies. Of course, these are the drugs which we are using in coronary artery disease patients beside stable coronary artery disease patients. And especially these drugs are used in stable coronary artery disease patients. Now, we are very much aware that there are 3 pillars of treatment for ischemic heart disease. One is the lifestyle management, in which you consider cessation of smoking, your change in dietary habits, and your exercise. This is one pillar. The second pillar is your, of course, optimal medical therapy, and the third is revascularization. So these are the 3 pillars for the treatment of ischemic heart disease. Coming back to this topic, we give these drugs as the primary anti-ischemic drugs, which I have mentioned here, and then of course we give secondary anti-ischemic drugs, or you will call antiplatelets or anticoagulants. Those are the drugs which are life-saving as well for unstable angina, for ACS, as well as for stable coronary artery disease patient. Now, where we are heading for? So I will stop here, and I will let the audience come up with more questions or their comments, or where we head for from here. My take-home message is, patients having stable angina with no left main disease, there is no compelling need to move on for revascularization. Those patients who have symptoms causing limitation to the quality of life, choosing revascularization strategy is a good option. This study talks about the merits, superiority of CT angiogram over stress testing, simple stress testing, and raises questions about its authenticity as well. Thank you very much.